So, Encik saya cuba tolak dari dalam macam ni, Encik cuba tahan. Okay, sekarang Encik cuba buat jadi macam ni. Saya akan cuba tarik. Encik tahan. And then for adduction, kita tu have a piece of paper. Okay, thank you. Okay, Encik cuba pegang, saya cuba tarik. Tapi Encik jangan bagi tarik tau. Okay, good. Tolong lepaskan. Okay, next, tolong lepaskan. Alright. So, another not bonus question lah, question for option discussion. How many abductors and adductors do we have for the fingers? Let's try, we discuss abductors first lah. How many abductors? Look at your fingers. So you have 1,
4, 5.
Okay. How about adductors?
3 only.
Why 3? Siapa yang jaga 3? No, it's just for discussion only. So
1, 2, 3.
partly correct, but remember for the fingers, right, we use the third finger as a reference point. So if the third finger deviates, if it goes this way or this way, it's also considered as adduction. Sorry, abduction. Yeah, the third finger has 2. Okay, so you have know at the end of the day you have 4. 2 here, 3 and 4 abductors. Alright. The little finger also has, but remember it's considered part of the hypothenar muscles. It's in its own group, so to speak. Alright. So we have already assessed flexion, extension, abduction, adduction. Now we should also assess thumb abduction and adduction. So tell me, this movement, what is it called? And this movement, what is it called? Whether it's, which one is extension and flexion of the thumb, which one is abduction and adduction of the thumb?
This one is flexion extension, right? Then this one is abduction, adduction, right? Yeah.
Yes, correct. Because this one is moving out of the plane of the palm. It's moving out like that. That's why it's considered abduction or adduction. This one, it's in the plane of the palm. So that's why we anggap this as flexion and extension. So, Encik, saya cuba tolak. Encik buat jari macam ni. No, position jari macam ni. Saya cuba tolak, Encik cuba tahan. Macam ni. Okay. Next, assess the pincer grasp. Encik tolong buat tangan macam ni. Okay, saya akan cuba tarik, Encik cuba tahan. Jari ni. Okay. That one you assess the C8 and PH1, C8 to PH1 nerve roots. And lastly, the power grip of the hand. This one is C5 to PH1. So, Encik, cuba genggam jari saya. Okay. And this is also significant because at this point you also want to check for the sign of another disease, myotonica dystrophica. So where in this disease, what we're looking for is, after the patient grasps your 2 fingers, you find it very difficult to let go and will take a long time to do so. Okay? So you assess 2 things at this point. We have already assessed all the muscle groups of the upper extremities. Next, you should check the reflexes. So what are the reflexes in the upper extremities? Okay. So for the biceps, to palpate the tendon, the biceps muscle, Encik kena relax. Okay. If the patient is lying down, you can just put his arm across his chest and then elicit the reflex from here. Not because you have to make sure the muscles are all relaxed. If not, it will be difficult to elicit it. Okay. And then supinator. Again, some say if you don't hit hard enough, then you don't need to put your fingers. Some say in order not to cause pain to the patient, then you put your fingers and you strike the tendon. So you assess the reflexes, and what you should note down in the case files after you assess each reflex, we assess it in the form of plus. Normal means 2 plus, 3 plus means increase but can be normal. You need to compare with the other side. 4 plus, greatly increase, already pathology. If 1 plus means decrease, 0 absent reflex. Okay? So we have assessed.
And plus minus is elicited with certain variable.
Yeah. Let's say sometimes the patient is nervous, then you can perform a certain maneuver to help distract the patient in order to help you elicit these reflexes. So what's it called, seniors? Okay. So you can either ask the patient to put his hands like this and say, okay, the time when I hit with the tendon hammer, you pull as hard as you can, or you ask him to clench his teeth. The main thing is you want to distract the patient from what you're going to do, and then you try again with the tendon hammer. All clear? Alright. So now we go to the lower extremities. This one you have to write down. So tell me, for the upper extremities, what was the first thing we checked? Tone. So we do the same thing here. Lift the leg up, and then we test movement at the ankle joint, knee joint, and also the hip. And then in the lower extremities, got something special that we want to assess: clonus. You can, I choose to assess it now because the patient, for it, the leg needs to be externally rotated and slightly flexed as well. So what you need to do is relax. You move dorsiflex the foot a few times very quickly, and then push upwards very abruptly. I'll demonstrate again. Encik tolong relax. Okay. Dorsiflex a few times and then abruptly. If it's pathological, you will see this movement will be sustained. More than 5 times is considered clonus, and based on what I've learned in Malaysia, if it's only once, then it's non-sustained clonus. And commonly what they do to assess clonus is this one at the foot. There's also another one which they don't perform as often. It's setting at the patella. The knee must be extended. You palpate for the patella, and you move it downwards briskly. And again, you will see that sustained movement. So we do that for one side of the leg, and then again we test with the other side. All normal. Now again we test for power of different muscle groups of the lower extremity. So first we are at the hips. We want to assess flexion, extension, abduction, adduction.